We have decades of randomized trials with implementation frameworks, and yet global treatment gaps persist despite the strong evidence. The architecture of care includes payment mechanisms, scope of practice laws, workforce pipelines. So why is mental health structurally separated from general medicine? How does the insurance design influence the things with you? Influence who can prescribe appointment length reimbursement, prior authorization requirements, telehealth coverages? What institutional levers can reduce all of these fragmentations? Why are behavioral and primary care still siloed? It's really sad. Why does it have to take me 2 hours to get a prior authorization for medication? Recognize that we're literally fighting architecture, not evidence. We have to advocate for better systems. Those financing decisions, their health outcomes, lives matter. Lives matter more. Lives matter more than the money. Hello. Welcome to the Transform Minds, the podcast where we explore the real world intersection of mental health, addiction, and transformative care. I'm your host, Dr. O. And with each episode, we take a thoughtful, practical, and evidence-informed look at how we can improve psychiatric and addiction care from our clinical settings to the community spaces. If you're new here, here's the vibe. CoastRx is just me and you breaking down the research and sharing what actually matters for our work. ExpertRx brings in brilliant minds from the field, whether they're clinicians, researchers, or change makers, we bring them in. And LiftRx, that's where real life stories come in. Guests who have lived it, they have survived it, and they're experts because of their experience and are reshaping the system because of it. Today, it is a host RX, and I'm so glad you're tuning in. And remember, as always, there's no clinical advice here. This is for educational purposes only. So let's get started. Treatment works. We have decades of randomized trials with implementation frameworks, and yet, a 2023 Lancet Psychiatry article makes it very clear. Global treatment gaps persist despite the strong evidence. If the science is solid, what about the system is unstable, not equitable? A 2023 paper in Lancet argues that mental health treatment gaps reflect structural system capacity, not patient-level barriers. If you remember our previous episode, it's sort of similar, and we're continuing with our structural system capacity and patient-level barriers that we were talking about. So we found a stark racial inequities in access to buprenorphine treatment. The American Medical Association also continues to call for enforcement of mental health parity laws. The 2023 Lancet article actually reframes treatment gaps as a consequence of system design. So we want to look a little bit more about that system design today. Specifically, the workforce distribution, underinvestment in community infrastructure, regulatory silos that is separating mental health from general medicine, financing models that incentivize volume over integration, and weak enforcement of parity regulations. This reframing aligns with the findings from, if you remember the study that we talked about, Legacity in JAMA, which showed that access to office-based buprenorphine was patterned by race and payment, demonstrating that system configuration determines different payment pathways. The architecture of care includes payment mechanisms, scope of practice laws, workforce pipelines, electronic record interoperability, zoning and site-in policies, benefit design. So these are structural determinants of treatment delivery. Is mental health care failing because we lack the knowledge or because we never redesigned the architecture to deliver what we know? I believe it's more of the latter because we continue to seek knowledge. So let's unpack why fragmentation is persistent, how financing becomes a clinical policy, and why pilot programs fail to scale. So why is mental health structurally separated from general medicine, you may ask? Psychiatry historically evolved within institutional frameworks, state hospitals, asylums, segregated funding structures. So when they began to deinstitutionalize mental health in that system in the mid-20th century, the community infrastructure was not proportionally funded. We haven't done that. We're tearing down the little infrastructure that we currently have today. In our current climate, we have fragmentation persistent despite evidence for integration. The collaborative care model has a strong empirical support in primary care settings. Randomized trials have demonstrated that we have improved depression outcomes and cost effectiveness. So why hasn't integration become default? Because scaling requires reimbursement redesigned to pay for the care coordination, workforce cross-training, shared liability frameworks, IT interoperability investment. Sustainable funding, not pilot grants. So Lancet Psychiatry article actually emphasized that countries with fragmented financing experience slower integration uptake. This implementation friction is not really weakness of the evidence. We don't have a research gap. The evidence for medication opioid use disorder, collaborative care for depression, early psychosis intervention, all of that is very robust. The gap lies between evidence and infrastructure. The research works. It clearly answers the questions, but the architecture, can we deliver it at a scale? How does the insurance design influence the things with you? Influence who can prescribe appointment length reimbursement, prior authorization requirements, telehealth coverages, behavioral health parity enforcement. It influences a lot. Research in general actually shows that policy analysis, it shows that parity laws exist, but they're not being reinforced. It's very inconsistent across different states. Reimbursement for behavioral health is lower than procedural medicine. Workforce distribution follows payment. So if I'm not getting paid, am I going to do that? You have to think about who's going to do the work if they're not getting paid. Why do pilot programs fail to transform into systems? I would say pilot programs demonstrate proof of concept, but the baseline reimbursement rates, workforce supply, regulatory licensing restrictions, healthcare incentive structures, without architectural redesigning, the pilot gains dissipate after the grant expires. So the money's gone. I can't continue what I started. We have peer-reviewed implementation that's suggesting that payment reform towards value-based behavioral health models can help. Integrated primary behavioral billing structures can help. Expanded scope of practice can help. Loan repayment, workforce expansion initiatives, technology infrastructure investment can help. But why is the redesign so slow? Why can't we invest in these things? Let's take a look at a case. We have a 29-year-old patient who has opioid use disorder and depression, and they present to your primary care clinic. The PCP cannot prescribe due to the institutional policies they have. Behavioral health clinic is a separate system. So insurance requires a separate authorization for them to get the behavioral health care. They don't have an integrated electronic health record system. So let's dissect this case. The evidence actually shows that clinically, immediate initiation of medications for opioid use disorder in primary care settings works really well. Collaborative care trials have demonstrated that depression improves when behavioral health is embedded in the primary care setting. Yet, we see this 29-year-old who is depressed, misuses opioids, and is seen at providing an institution that's restrictions are currently overriding what the evidence we just talked about says. There's this administrative friction that's delaying initiation of care for this patient. There's this fragmented record that increased risk of loss to follow up because we're not in the same EHR. Now I have to call for care coordination when I could have just clicked the file, open the chart, and see what happened over there with your primary care provider. The architecture is functioning as designed, even though it's misaligned with evidence. This is the structure that we have. So for our clinicians, where is architecture interfering with standard of care? I want you to take a pause and think about it. Where has your system design interfered with the standard of care that you're required to provide? If you think about your institutional prescribing policies, is it exceeding the federal requirements? Are you spending hours and hours getting prior authorizations? That's creating so much delays and your patient can't get their medications. Evidence-based care is actually being delayed because of all these policies. From insurance side, from our institutions, from so many different areas and arenas. What institutional levers can reduce all of these fragmentations? Can we advocate for removal of internal prescribing restrictions? Like if the policy does not make sense and it's causing patient delays, can we push it out? Can we integrate our EHRs? Documentation delays, all of these things, can we do something about it? How can collaborative care help? Co-located services, warm handoff. I just learned something recently from one of my mentors, because we always talk about warm handoff, and she taught me hard handoff, cold handoff. Because the warm handoff is like, oh, hey, this is the patient, connected you to your PCP, connected you to your counselor, the therapist, the psychiatrist, and that's it. But can we do a cold, hard handoff where we're checking in a month later, 3 months later, 6 months later to see, did the patient connect? Also, were they lost to follow up or did they continue the care? It's not just that I connect them. Did they follow through? Were they retained in the treatment? What I did it work? Is there something I need to adjust in my process of connecting people to specialty care? From behavioral health to the PCP. All of these things. So that's what I had learned from her. And I was like, I will do that. I should be doing that. Because these warm handoffs are increasing loss to follow-up. Like warm handoff could be, hey, I walked you to the PCP, but something happened, you didn't make the appointment, but I didn't follow up and the PCP didn't follow up, so you never got an appointment, even your first appointment. Shared case conferences. Can we discuss cases together? Because then we can learn from each other. When I was a medical student, where I did my pediatric rotation, I would rotate in a clinic, and in the area, there was not a child psychiatrist, in proximity. So what the pediatrician would do was connected to a larger institution that had specialty care. And he would call when he had a child that had some behavioral health problem or depression, anxiety, anything. And he felt like, okay, I needed support in treating this, or I needed specialty expertise. The doctor would virtually evaluate the patient, the specialist, and that's how child psychiatry was integrated into that pediatric clinic. Literally, cases would be discussed. So case conferences are a great way. This is slightly not a case conference because it's still collaborative care, but shared case conferences. Like at my institution, we have weekly team meetings where therapists, psychiatrists, the entire team, we come together, we discuss the cases. We all learn from each other. So if we could do this across specialties, that would be great. We can learn from each other. Teleconsult psychiatry integration, that's what I just talked about. We could do that. Evidence show that integration improves engagement and outcomes. Touch points that a patient is going through, that an individual is going through. So they're going to connect more. For policymakers and the general public, why are behavioral and primary care still siloed? It's because of finance and streams. They've evolved separately and remain structurally divided. Reimbursement and regulatory frameworks have reinforced that separation. So how do reimbursement rules shape possible care? If coordination time is unpaid, it is deprioritized. I will tell you that. The people that work in the healthcare system, they're less likely to spend time calling A, calling B, calling C to coordinate care because they're not getting paid for it. And it's eating into their time to see other people. It's going to be deprioritized. That's just what it is. If prescribing is an administrative burden, it is going to be underutilized. If it's going to take me 2 hours to prescribe this medication, but I could prescribe that other medication in less than 2 minutes, I would do the less than 2 minutes. And I'm not saying me personally, it's a scenario. Because why does it take 2 hours for me to get a prior authorization over the phone? And I know cover my meds and all of that. Cover my meds sucks sometimes. You could try so many times and it doesn't work. Cover my meds sucks sometimes. So sometimes you just have to call the insurance, and sometimes it takes so long for someone to even just pick up the phone, like 30-20 minutes before someone picks up the phone for you to do a prior authorization so someone can get their medication. It's really sad. Why does it have to take me 2 hours to get a prior authorization for medication? So what does integration truly look like? A single reimbursement structure for the whole person care, embedded behavioral health in primary care settings, shared electronic system. Epic is great. So many hospitals use them. You could see, regardless of which hospital they went to, you could see it in there. It's all in one system. No redundant authorization barriers. Integration is architectural, not rhetorical. Somebody has been taking medication for years. Why do I have to do a prior authorization every 6 months? Like, why? Let's look at the different levels, like the 3 levels of healthcare system. So the first level is the clinical architecture, right? Treatment guidelines, prescribing authority, and workflow design. And then you have the organizational architecture, which is level 2, where you have your payment models, your hiring structures, your IT systems, and liability policy falling under this level. And then you have your level 3, which is really the main policies: insurance benefit design, the scope of practice law, federal parity enforcement, Medicaid expansion decisions. Like, most clinicians are trained at level 1, but most barriers are occurring at level 2 and 3, like we've already talked about. Like insurance problems, IT problems, like all of these things, they're fallen at a different level where the clinician is not there. So if we only optimize clinical decision making, but we turn our backs on organizational and policy architecture, the treatment gaps are going to persist. So we really need to think about the next time you encounter delayed care. Ask yourself, is this a clinical issue, or is this a payment, IT, or regulatory design issue? Because once you're able to identify and name what type of issue it is, what level it falls under, whether clinical, organizational, policy level, like level 1, 2, or 3, whichever level it falls under, once you're able to identify that and name it, you shift from frustration to a structural analysis, and then you can begin to design. And I always say this: if you can PDCA the problem, do it. It don't matter how many cycles of PDCA it takes. If you can do it, do it. So for our clinicians, recognize that we're literally fighting architecture, not evidence. We have to advocate for better systems. As clinicians, it's not just clinical. We have to advocate for more structural literacy. It's literally part of professional competence. If you're a trainee, if you're a policymaker, those financing decisions, they're health outcomes, but lives matter. Lives matter more. Lives matter more than the money. And for everyone else listening, fragmental care is not random. It reflects the design choices that we've made. So like when we look at our study today, what it's reminding us is that persistent treatment gaps reflect our structural capacity decisions that we're making. Architecture is determining our delivery. The delivery determines our outcomes. And we can redesign our current health system architecture to give us better outcomes. We can have better outcomes. So thank you for coming. See you same place, same time, every second and fourth Tuesday of the month. And as always, stay ready, stay aware, and stay grounded.